Hello everyone, I'm Orsolya Gresits, one of the PhD students at the Department of Orthopaedics. I have two projects in this translational medicine program. The first one titled No Evidence of Functional Benefit After Upper Limb Botulinum Toxin Treatment in Children with Cerebral Palsy. Actually, that's what it's all about, but I'll go a bit more into the details. Cerebral palsy is a condition which is the leading cause of childhood disabilities, and about 80% of them has spasticity. One treatment option is to inject those muscles with botulinum toxin. I want to talk about upper limb botulinum toxin injections. They are widely accepted and used in cerebral palsy for more than 30 years. They bring a temporary focal spasticity reducement. They definitely have a green light, so they are supported to use, but still there's quite many uncertainties about this treatment. We are unsure about the functional benefits, and there's questions about the indications as well. So we had two aims when we started this project. The first one was to compare the upper limb function of cerebral palsy children who were treated with Botox to those, to similar children who did not have any Botox but just conservative therapy. And the second aim was to clarify indications for this therapy. You see the PICO framework we work with. And after the selection, we ended up with 13 different studies. And we have quite many eligible outcomes, but I only want to show you 4 today, so have no fear. The first one is about the muscle tone of the elbow flexors, measured by the so-called S-word scale. It's a scale which goes from 0, meaning normal muscle tone, to 4, which is the more serious rigid state. And in this plot, you can see in the upper half was measured during the toxin effect, and there was a meaningful and statistically significant decrease during the toxin effect, which vanished after the toxin stopped working. The second result slide I'm showing you today is about the minimal to no functional improvement we found investigating different functional outcomes. As an example, here's the pool results of the so-called Melbourne assessment. You can see the test on the right side. The kid has to play different play tasks, like putting that toy car in the tube, and then gets a point. A higher score means better upper limb function, and actually no or minimal functional improvement was found in all functional scales we investigated. The third one I'm showing you today is about the improved goal achievement with botulinum toxin treatment. A really important aspect of cerebral palsy treatment is that we always define goals with the kids. So there are pre-defined goals, and there's a goal attainment scaling, which is shown in this graph, which is a really complicated measurement method, but actually the higher score the kids get, the better goal achievement they have. And this graph shows that kids treated with botulinum toxin have definitely better goal achievement than kids not treated with botulinum toxin. And the very last result slide I'm showing you today is about the parents' option about the treatment. Parents were asked if they think their kids improved or not with the treatment. and that was rated on different scales to make them comparable. We dichotomized all the outcomes to having an improvement or not having an improvement, and calculated odds ratios. And as you see here, robust improvement was, so botulinum toxin treated kids did better, way better, 2 weeks after the injection, 3 months after the injection, even 6 months after the injection. Yeah. To summarize, the main strength I want to report is that we had really homogeneous population and a very similar intervention process all across the included articles. So that's make our work a great generalizability. On the other hand, there are some limitations to note. There was a huge heterogeneity in the measurement tools used, a huge heterogeneity in the injected muscles, and also data reporting practices were not ideal to do meta-analysis. So we had problems by pooling, sometimes even made impossible for us to pool the data. From what I said, we can conclude that traditional functional scales are probably not the right tool to evaluate the effects of upper limb botulinum toxin therapy, and that the only proven indication is still spasticity reducement. As an implication for practice, the following should be noted before the treatment: that it reduces muscle tone, but simultaneously grip strength, and no functional improvement should be anticipated. But somehow, parents still like this treatment. And as an implication for research, we know 3 fields where future study might be useful. I think the most important one is the last one, to study spasticity itself, to better understand why parents like this treatment so much. And this project has an ongoing plagiarism check, so we will hopefully submit it soon. Let me move to my second project. Does femoral derotation osteotomy improve gait in cerebral palsy? We have the very similar patient population here. Cerebral palsy kids, they develop gait difficulties over the time. One common gait difficulty is the so-called in-toeing gait. There's a major surgical procedure called the femoral derotation osteotomy to treat that problem. It's a really common surgical procedure. We know that it's definitely beneficial from cosmetic, so it brings better cosmetics, but we are unclear if it affects the gait positively. So with this work, we want to clarify if this FDO surgery has a positive impact on the gait function itself. Please see our framework here, and we think that FDO surgery has a positive impact on the gait. And so this project is under data extraction right now. To summarize, I have these 2 projects, and I want to thank you for your kind attention. Thank you.
When reading the first draft or your manuscript and also listening to your presentation, it made me think whether what is the best primary outcome, or what would be the best outcome for these kind of studies in patients in children with cerebral palsy. Is it really the improvement in the children or improvement in parents? I mean, these parents must be severely distressed, right? And so my question is that, because in your first project, the most important outcome is that the parents genuinely experienced improvement in their children. Is that correct?
Yes.
And can we assess whether these kind of improvements, that the child can step a little bit further, can speed up, increase, improved gait, whatever. Do these children really experience that as an improvement, or are they indifferent? So do you get my drift?
Yep.
So is it the child or the parents who we should focus on in these kind of studies?
First of all, thank you for your question. It's a really interesting topic. And we investigated different outcomes. There were outcomes investigating the burden of the caregivers. There were like health-related quality of life for the kids and also for the parents. And there wasn't any differences between the Botox-treated and not treated groups. So unfortunately, they were not numerous enough to be pooled and put on forest plots, but there were some studies which investigated those things you mentioned, and there wasn't any difference between the two groups. So that's why we are unsure what would be the right outcome.
Yeah, but your results contradict that, because you in fact found that parents were more satisfied with the Botox treatment.
Yeah, but that's a highly subjective outcome, and that's what we have.
But we all live a subjective life, you know.
So that's what we have today.